Let's start by reviewing the purpose of the Emergency Preparedness Plan. Home health care staff have the unique expertise of caring for patients in a non-clinical setting. They are well-trained, well-educated, and well-equipped to provide this type of care. Let's think about what happens to hospitals during an emergency. Hospitals must take the critically wounded and triage their resources. Anyone currently in the hospital may be discharged in order to make room for more critically ill patients. In these situations, we may be called on to help our community. It is also very important to be able to provide continuous home care to our patients as to not add stress to an already overwhelmed healthcare system. Our mission and purpose of having an emergency preparedness plan is to identify hazards most likely to affect our agency. Then we need to determine strategies to mitigate or lessen the effects of these hazards and determine our ability to manage these hazards should they occur. From a community standpoint, it is important that we work together to prepare and protect our communities and increase our ability to respond and recover from emergencies. Most of us live in the communities that we serve in. It should be important to all of us that this agency is doing our part to create and nurture a resilient community. So what are our goals and desired results of a successfully executed emergency preparedness plan? The first goal is that our employees will be safeguarded and protected. Secondly, we want to be sure that our business can continue to function. Monies will be collected, bills will be paid, staff will receive a paycheck, etc. Next, we want to make sure that we protect our physical assets, such as buildings and property, the actual stuff within our buildings, medical records, etc. We also need to make sure that our patients continue to receive excellent and continuous care. Finally, we want to make sure that our agency brand and community image is preserved throughout an emergency. While this might not seem important on the surface, I feel that by showing that we are prepared for emergencies, we are showing that we have a vested interest in the safety and well-being of every individual living in the community. On the flip side, if we are not prepared, we are being irresponsible, and we feel that our staff and patients deserve the best. These staff members are part of the emergency planning team. They were instrumental in getting the plan started, and we continue to work to improve and refine the plan on a regular basis. It is important that as an agency, we participate in proactive planning. All staff must make themselves familiar with our plan and participate in training sessions and exercises. The first time to look at this plan is not when we are in the middle of an emergency. We should not be trying to determine where are the tornado shelters when we can actually see the tornado out the window. Now let's move on to the authority and reference portion of the training. Let's first start by reviewing the actual regulation as cited by CMS. This new regulation affected 17 different healthcare provider types, home health and hospice being 2 of the 17. There really wasn't any type of healthcare provider left out, and if you think about it, that makes perfect sense. If our whole goal is to create and nurture a resilient community, and you leave the hospital out of the mix, you will have a huge missing piece of the puzzle. We all must work together, and having the regulation affect the majority of healthcare providers promotes this partnership. Some rules apply to hospice and not home health, and vice versa. In general, we have implemented the more stringent rule for both lines of business. The regulation contains 4 main parts that are required to maintain compliance. The first is an emergency plan that is created based on an all hazards risk assessment. The second is policies and procedures. The third is a communications plan, and finally is the training and testing piece. Our plan document includes all of these parts. During an emergency, it is important to know who is in charge and who has the ability to make a decision. Again, if you remember back, we want to practice proactive planning. So we want to know in advance who is the agency's authoritative spokesperson. This person is our executive director, or Wendy Starr. If she is unavailable or unable to manage an emergency, then the chief financial coordinator and the chief clinical coordinator will equally succeed in management. These staff members are Christina Kennedy and Barbara Dixon, respectively. There will be emergency situations occur that may require an immediate decision be made. This decision can be made by the coordinator in charge. In London, it is Barb Dixon, then Emily Johnson, and then Karen Miller. For the annex, it is Christina Kennedy, one of the patient financial counselors, and then Tiffany Elrod. Finally, for Marysville, it is Amy Blumenshine, Jason Lambert, and then Sarah Queen. For hospice, we are required to have a memorandum of understanding with another hospice. Basically, this is an agreement to receive patients into our program or provide staff support to another agency should an emergency occur. The partner agency also agrees to do the same for us in case we have an emergency. Currently, we have a memorandum of understanding with Heartland Hospice for both counties. The next portion of our training is a review of the hazard assessment as completed by the emergency planning team. First, let's define what an all-hazard assessment entails. By definition, it is an integrated approach to emergency preparedness planning that focuses on capacities and capabilities that are critical to preparedness for a full spectrum of emergencies or disasters. Phew, that is a mouthful, but still, what does it mean? It means that we do not have to plan for every possible hazard, situation, or scenario that could occur, but it does mean that we should consider all possible hazards as part of our risk assessment. We must evaluate our service capacities and capabilities to ensure that regardless of the hazard or situation, that we can provide continuous care to our patients. The emergency preparedness team completed an all-hazard risk assessment. We have concluded the top 5 hazards or threats to our agency are epidemic, pandemic, ice storm or winter weather, tornado, severe thunderstorms, and extreme heat. The hazard assessment will be reevaluated on a regular basis by the planning team. Our first and number 1 hazard from the assessment was an epidemic or pandemic. So what is the difference between an epidemic and a pandemic? An epidemic is typically a disease that occurs in a larger number of people than normal in a localized area. A pandemic is a disease that spreads over several countries or continents and affects a large number of people. If an epidemic or pandemic were to strike, there are many potential results of such emergency. One of the biggest challenges we could face is not being able to care for our patients due to lack of resources. Our staff could be sick or could be forced to stay home and care for their own sick family members. Another potential challenge would be that we could have sicker patients who may find themselves in a more dire health situation than before the epidemic. In catastrophic cases, we could have staff deaths, increased patient deaths, quality of care impacts, and permanent loss of key resources. So what can we do to prevent or mitigate the risks associated with an epidemic or pandemic? Most of our mitigation strategies revolve around education of our staff, patients, and patients' family and caregivers. Proper hygiene techniques are the key to preventing the spread of disease and illness. It is important for our patients to plan ahead if this threat becomes imminent. One of the big things that patients should plan for is the sudden loss of a caregiver. They should plan on a backup in advance just in case their primary caregiver becomes ill. In addition, our field staff will be called on to help with syndromic surveillance. Basically, this just means to stay alert and be ready to identify patterns of symptoms within our patient's census. If strange patterns are noted, they should be immediately reported to the home health or hospice coordinator. The next major hazard that we identified was winter storms. Winter storms include ice, snow, below freezing temperatures, and blizzard-like conditions. Most of the potential results mirror that of the epidemic and pandemic. However, now we are dealing with the potential for loss of utilities in impossible traveling conditions. This hazard has a great potential for cascading events to occur. First, the electric goes out. Then, we don't have heat, which now could mean we don't have water, and the list continues. Poor road conditions and low visibility during winter storms can shut an entire community down for days. Mitigation strategies again center around education of our staff and patients on what to expect during winter storms and how to properly prepare. Patients should be sure to have supplies available in case they become stranded at home for several days. FEMA has stated that people within any given community should be prepared to be on their own for at least 72 hours following a disaster. Planning ahead is required to meet this 72-hour window. Staff should make sure that they have properly winterized their vehicles and have prepared for the possibility of being stranded in their vehicle for hours. Proper maintenance of furnaces and HVAC systems also help keep everything running smoothly during the cold winter months. This slide is a listing of snow emergencies and the definitions of each as defined by the Sheriff's Office. It is important to know the difference between each and what your plan of action will be at each level. For clinical staff, during a Level 1 snow emergency, everything is pretty much business as normal. You are expected to see your scheduled patients for the day, and any deviation from your schedule requires prior authorization from your coordinator. During a Level 2 or Level 3 snow emergency, we have designated a first responder that is responsible to coordinate all patient visits for the day. The home health coordinator, Emily Graves, is the primary first responder for all home health staff, and the chief clinical coordinator, Barbara Dixon, being the backup. The hospice coordinator, Amy Blumenshine, is the primary first responder for all hospice staff, with the chief clinical coordinator, Barbara Dixon, being the backup. When there is a Level 2 or 3 snow emergency, it is the responsibility of each case manager to contact their assigned patients for the day and identify who needs a visit that day. After making this determination, they will contact the appropriate first responder and alert them of who needs a visit if conditions improve, who could be moved to another day, and who is a missed visit. The first responder will then work with the scheduling coordinator to get the visits taken care of. The first responder is also responsible to contact the sheriff in the case of a Level 3 snow emergency. For administrative staff, during a Level 1 snow emergency, again, everything is business as normal. You are expected to work your shift as scheduled, and any deviation requires prior authorization from your coordinator. During a Level 2 or 3 snow emergency, the administrative coordinator will pretty much be making a game time decision regarding the availability of the clerical staff and ensuring that phones are handled as normal. The chief financial coordinator will determine how the patient financial counselors will report for their shifts. They will most likely be asked to work from home that day. The third hazard identified was tornadoes. With Ohio weather, tornadoes can practically occur any time during the year, but most prominently in the spring and fall. Most of the potential results again mirror that of the previous two hazards. However, now we are dealing with the potential for loss of structures. Patients may lose their homes, or caregivers could lose their home, resulting in a loss of caregiver situation. Our staff may lose their homes, our office structures could be severely damaged, requiring us to relocate our operations. Again, we are focusing on educating staff and patients on having a plan on what they would do if a tornado were imminent. Moving into 2018, we will begin performing tornado drills at least 2 times per year, once in the spring and once in the fall. These drills will be used to keep staff's mind fresh on what to do if there is a tornado during working hours. If there is a tornado warning during business hours, there will be a notification that there is a tornado warning and that you should seek shelter immediately. This does not mean that you should finish a task first and then seek shelter. Should you hear the warning, you should head toward the shelter right away. Performing drills will help staff become familiar with emergency shelters prior to the actual emergency. Should you be in the main London office, the men's restroom is the best safe room. Both the Annex and Marysville office have basements. If you are a potential coordinator in charge, daily you should be asking yourself, should an emergency occur today, am I the coordinator in charge? This will help you maintain an awareness at all times and allow you to respond quickly should an emergency arise. After the coordinator in charge has made sure that all staff are safe, they will send out a broadcast click message alerting all staff of the impending tornado. The fourth hazard is the precursor to the tornado, severe thunderstorms. Again, with Ohio weather, we could experience a severe thunderstorm at any time during the year, but mainly in the spring, summer, and fall months. The potential results are very similar to that of tornadoes and the previous two hazards: loss of utilities, loss of facilities, loss of caregiver, and resource restrictions. The mitigation strategies are again focused on education. Here, we are also drawing attention to planning. Staff and patients should plan ahead and determine what they would do if they are on their own without help for an extended period of time. The final main hazard from the hazard assessment was extreme heat. The key potential risk here is that extreme heat highly impacts patients who are already in a vulnerable health situation who may require evacuation. Our main mitigation strategy to keep the impact on patients low is to perform diligent patient check-ins during extreme heat events. We need to focus most of our attention on patients who do not have air conditioning. We will constantly be assessing their situation to determine if an evacuation is required. In this next section, we are going to discuss something that, in my opinion, has become an epidemic in America. Let's first discuss the difference between an active shooting event and a workplace violence shooting event. An active shooter typically does not have an intended target. Their main goal in a shooting is to kill as many people as possible before they are stopped by law enforcement. A lot of times, the shooting ends with the gunman taking their own life. Again, there is typically no pattern to the violence or a specific victim selection. Think about the recent event that occurred in Las Vegas. The gunman shooting from the hotel window had no idea who he was killing, and to him it was irrelevant. In a workplace violence shooting incident, there is typically a main target in mind. The shooter will generally not harm anyone else aside from their target. The shooter will generally only injure someone who gets in their way of their intended target. So what do we do if a shooter, either active or workplace violence driven, arrives in one of our buildings? Run. Your goal should be to get low, get quiet, and get out. If you have an office window, use it to get out. If you have to hide, lock the door, turn off the light, and be quiet. If cornered, you always have the option of fighting. It is hard to fire a gun if the target is throwing debris at your head. Never, ever try to negotiate with the shooter. When they arrived, they had their mind made up. In this day and age, everything is computer-based, and with that comes the opportunity for criminals to steal information in digital format. It is especially critical for our agency to be extra diligent to protect the confidential information of our patients and staff. Being hacked is a very expensive road to travel. The HIPAA fines themselves could be enough to cripple an agency of our size. In addition, viruses such as ransomware hold information hostage until the agency can pay the ransom. Not being able to access our information would leave our staff being very unproductive. In situations with ransomware, if you decide to not pay the ransom, they will most likely sell all of your data to the highest bidder on the dark web. There are many things that we can do to prevent such incidents. Being able to control who has access to our facilities, computers, tablets, devices, and programs is a good step forward and is likely the best prevention technique. In addition, we should all practice good cyber hygiene, meaning change your passwords on a regular basis and make sure that they are strong passwords. Do not visit suspicious or unsafe sites while using agency devices. These two things will do wonders at keeping our data safe. We are all familiar with the random acts of terrorism that have occurred throughout the years. The Oklahoma City bombings and 9/11 left us stunned and shocked in the aftermath. There are several types of threats, including biological, chemical, and explosives and bombs. This threat is such a broad area that it would be impossible to plan for all types of scenarios. During these situations, we will follow the orders and advice of our local emergency management officials. If we were to receive a bomb threat, the person receiving the call should try and gather as much information as possible. They should immediately notify the coordinator in charge, who will make contact with the local authorities. Chemical and hazardous material releases occur with train derailments, traffic accidents, chemical plant explosions, etc. As with acts of terrorism, this threat is such a broad area that it would be impossible to plan for every scenario. Again, we will follow the advice of emergency personnel should an incident occur. The next threat and hazard are fire emergencies. OSHA regulations require that we have a fire prevention plan, which is covered in our emergency preparedness plan. Some things that we can do to prevent fires are to check smoke detectors, exit signs, and fire extinguishers on a regular basis. We should always make sure that means of egress are not blocked as to promote easy evacuation should it become necessary. If there is a fire in one of the buildings, you are to get low and get out of the building. You should evacuate through the exit that is farthest away from the fire yet closest to you. Do not attempt to put out the fire with the fire extinguishers. Exit the building immediately. Prior to a fire emergency, make yourself familiar with all exits and have a plan in mind of what you would do. During the upcoming year, we will be doing several fire drills to practice and keep our plans fresh in mind. After exiting the building during a fire emergency, folks in the main building should gather in the annex driveway. The annex staff should gather directly across the street from the building. Marysville staff should gather in the front lawn. Once all have been evacuated, the coordinator in charge will call 911. If there is a fire in the patient's home while you are there, you should attempt to get the patient and any other occupants out of the home. If the patient's condition does not allow this, get the patient as low to the ground as possible and close the door to their room if applicable. Once you have done this, get yourself and all other occupants out of the home and call 911. After making the 911 call, contact the office to make them aware of the situation. Let's move on to sheltering in place. In certain emergency situations, it may become necessary to shelter in place if the outside air becomes contaminated and non-breathable. If this happens, we may be ordered by local emergency staff to shelter in place, meaning stay where you are until it is safe. Each building has a designated safe area that can be sealed off in the event that we have to shelter in place. All windows and doors will be sealed off using heavy-duty plastic and duct tape. The safe room in the annex is the conference room, and in the main building is the executive suite. In Marysville, the kitchen area is the designated safe area. Each safe area will have a shelter-in-place kit that includes instructions on how to properly seal the area, pre-cut plastic, duct tape, water, energy bars, extra toiletries, blankets, and flashlights with extra batteries. There are many different hazards that could cause us to evacuate the building. Should the need arise that we are ordered to evacuate our building, employees should exit the building in an orderly fashion. They should exit the building using the exit closest to them and farthest away from the hazard. The coordinator in charge is responsible to ensure that all staff are out of the building. Our next topic is the Incident Command System, or ICS. The Incident Command System is a national system used to manage all domestic incidents. FEMA, state emergency management, and local emergency management teams use ICS to manage emergencies of all sizes. The purpose of ICS is to identify tasks, allocate resources to accomplish these tasks, and establish accountability for the completion of tasks. Our emergency plan has adopted the ICS methodology to manage our emergency incidents. It is important to note that in a major disaster with multiple agencies and levels of jurisdictions, that things can get confusing very quickly. By using ICS in our agency, we will be speaking the same language as all other emergency management staff, which will make communications much easier. When the ICS is activated, staff members who are normally in charge may not be in charge, and staff may report to someone else during an emergency. This is an organizational chart that describes the different roles in the ICS. We will not get into this in much detail in this basic training. All staff who will be directly involved in the ICS have and will continue to receive in-depth training. All other staff should just be aware of the ICS and the general information as presented here. Next, let's move into the next part of the regulation, which is the communication plan. In general, we have multiple methods for communicating with our staff. It is important during an emergency situation that we are able to locate all of our staff members quickly. While there are multiple methods of communication, we have selected the CLIck application as our primary method of alerting staff during emergencies. We also have several different methods for receiving communications during emergencies. The Central Ohio Healthcare Disaster Information Management System is a very unique and helpful tool during emergencies. Basically, it is a web-based system that allows us to communicate with other healthcare providers throughout the state during emergency situations. This is especially helpful for hospitals to be able to communicate with each other regarding equipment needs and bed availability. The communication regulation requires us to make contact with all of our staff if an emergency situation arises. If an incident occurs, all staff will be alerted via the CLIck messaging system within 30 minutes. All staff are required to respond to this alert. In the message back, we are looking for your location and your status. The response could be, "I am home and I am safe." Or the response could be, "I am in my car on Walnut Street and I need help." If we have not heard back from you within 15 minutes, we will begin to use additional communication methods to try and contact you: texting, phone, email, etc. We can also do a GPS ping within CellTrack and find you. If we are unable to locate you, we are required to contact the local emergency management team and tell them that you are missing. The whole purpose of this regulation is to make sure that all of our staff are accounted for in emergencies. I know that everyone can rest easy knowing that if there is an emergency or disaster, that someone will be looking for them. The communication regulation also requires us to make contact with all of our patients during an emergency, regardless of if the emergency directly impacts them or not. It is our goal that during an emergency situation, all patients will be located and their status assessed within 1 hour. This may seem silly that if our patient resides in Richwood and there is a tornado in Mount Sterling, why would we need to call them to make sure they are okay? But what if it happens that that patient is visiting a relative in the Mount Sterling area? It is critical that we are able to locate all of our patients to ensure their safety. The case manager is responsible to contact all of the patients they manage and assess if they are safe, what is their clinical status, are they mobile, what they need right now, does the patient priority code need changed, and does the patient require evacuation or emergency support. If the case manager is successfully able to make contact with the patient and they learn that the patient is safe, they should relay this information to the operations chief or their coordinator. The case manager should make a follow-up call to the patient every 12 hours to ensure that their status remains stable. All patients not directly impacted should receive a follow-up call the next day. If the case manager is successfully able to make contact with the patient and they learn that the patient is not safe and may require evacuation, they should immediately alert the operations chief or their coordinator, who will then make the appropriate notifications to the authorities. They will also relay any pertinent evacuation needs to the emergency management team. The case manager should remain in close contact with the patient until the evacuation has occurred. Once the evacuation has occurred, the case manager shall make every effort to document where the patient is being evacuated to. If the case manager is unable to successfully make contact with a patient, they should continue to make contact with the patient and their emergency contacts at least 4 times over a 20-minute period. If they still cannot make contact, they should immediately alert the operations section's chief, who will make the appropriate notification to authorities. As a general rule, during emergencies, loving care will only call upon already established volunteers to make phone calls and perform patient check-ins. If a volunteer would like to participate and be involved in emergency operations, they will receive additional emergency preparedness training. During emergencies, volunteers will report to either the operations sections chief if the IC has been activated, or the chief clinical coordinator if the IC has not been activated. Assuming that all of our patients are safe and cared for, we would be able to provide the following services to the community during an emergency situation: medical support, crisis and grief support, hospital surge support, receiving transfers via memorandums of understanding, first responders, first identifiers, and closed point of dispensing. We currently have a contract in both counties to act as a closed point of dispensing. This means that if there was an incident that would require mass vaccinations or preventative drugs, we would be able to administer these vaccinations or drugs to our staff, staff's family, patients, patient's family, and any other homebound individual within the community. So what does responding to medical surge mean to our agency? During emergencies, hospitals can become quickly overwhelmed with trauma cases. In these situations, they may start discharging lesser ill patients back to their homes with the assistance of home health. Our challenge will be to accept as many of these patients as we can and also work hard to ensure that our current patients in the community are well managed in order to keep them from needing acute care services. Moving on to safety and security. During an emergency situation, clinical staff should do the following: Remain on high alert while traveling during emergencies. Stay in close contact with your coordinator or the medical branch director to understand your roles and responsibilities to patients. Only enter areas that have been deemed safe by the incident commander. If it is determined that a case manager cannot see a patient because it is unsafe to do so, the case manager should make contact with the patient to assess their status. If it is determined that the visit can wait, the case manager should wait to make the visit, but should continue to contact all Level 1 patients every 4 hours to ensure that their status has not changed. If the patient's condition is such that immediate medical attention is required, the case manager should alert their coordinator or the operations sections chief so that emergency management authorities are aware that an evacuation needs to take place. During an emergency situation, office staff should do the following: remain on high alert during emergency situations. Stay in close contact with your coordinator or the business continuity director to understand your roles and responsibilities to the agency. Be prepared to shelter in place or evacuate if the emergency deems it appropriate. If your position requires you to enter other facilities, you should always make yourself familiar in advance with emergency exits, evacuation plans, and tornado shelters. You should also make sure that facility staff members are aware that you have entered the building and that they are also aware when you leave the building. If an emergency occurs while you are in another facility, report to the nursing station or the designated gathering area and await further instructions. Keep in close contact with your coordinator through the entire situation. Let's now talk about the responsibilities of staff in regards to business continuity. It is important that during emergency situations, our business continues to function as normally as possible. Payroll, billing, collections, and other administrative duties should continue as normal. The business continuity director is responsible to manage all administrative staff resources, all administrative activities, and ensure adequate office equipment and supplies are available. Billing and collection operations shall be maintained just as efficiently as normal. These tasks are accomplished primarily out of the annex. Should this building become compromised, the main building is the primary backup, and the Marysville office is secondary. These tasks could also be completed out of the staff's home under certain circumstances. Accounting operations shall be maintained just as efficiently as normal. These tasks are accomplished primarily out of the annex and the main building. Should one of these buildings become compromised, the remaining London building is the primary backup and the Marysville office is secondary. These tasks could also be completed out of the staff's home under certain circumstances. HR and payroll operations shall be maintained just as efficiently as normal. These tasks are accomplished primarily out of the annex and the main building. Should this building become compromised, the remaining London building is the primary backup and the Marysville office is secondary. These tasks could also be completed out of the staff's home under certain circumstances. Let's talk now about facility and utility management during emergency situations. After an emergency has occurred, it is the duty of the infrastructure branch director to perform an assessment of the following at each building in both locations: the access points and the functioning of utilities, the facility's physical stability, the facility's physical security, including staff safety, property security, and medical record security. The shutdown manager is responsible to lock doors, secure the building, and shut off any appropriate utilities during an emergency. In the main London building, Darlene West is the primary and Robbie Huddleston is the backup. At the Annex, Christina Kennedy is the primary, and Cynthia Tremaine is the backup. Finally, in Marysville, Sarah Queen is the primary, and Amy Blumenshine is the backup. The general procedure during a power outage at the office is as follows. The office manager or coordinator in charge is responsible to contact the electric company and determine outage length. They will continue to follow up until the electric is back on. Non-essential staff may be sent home at their coordinator's discretion. Staff with the ability to work at home will be encouraged to do so. If a power outage were to occur, the administrative coordinator will make a decision regarding how phone calls will be routed and handled given the situation. If our patients are experiencing a power outage, the case manager should make regular contact with the patient to assure their safety throughout the outage, especially those patients on life-sustaining support. All safety concerns should be addressed immediately. Prior to an outage occurring, the case manager should review the emergency preparedness guide with the patient and encourage them to develop a plan based on their needs. Those patients with life-sustaining devices should contact the electric company and ask to be placed on the priority restoration list. The general procedure during a heat or water outage at the office is as follows. The office manager or coordinator in charge is responsible to contact the appropriate company and determine the outage length. They will continue to follow up until the heat or water is back on. Non-essential staff may be sent home at their coordinator's discretion, and staff with the ability to work at home will be encouraged to do so. If an outage were to occur, the administrative coordinator will make a decision regarding how phone calls will be routed and handled given the situation. The general procedure during a gas leak at the office is as follows. The office manager or coordinator in charge is responsible to contact the gas company and determine the issue. They will follow all instructions given by the gas company, which could be to evacuate the building or shut off the gas. If a gas leak were to occur, the administrative coordinator will make a decision regarding how phone calls will be routed and handled given the situation. Moving on to patient care and protection strategies, as well as emergency planning with patients and their families and caregivers. As a home health and hospice agency, we serve a high-risk population with multiple access and functional needs and disabilities. It can be assumed that, depending on their level of need, if a patient's services are disrupted, it could lead to a rapid decompensation of health and an increased reliance on acute care services. It is critical that we make sure that our patients and their families are well prepared for emergencies, and we should also help them develop a plan to endure emergencies and recover effectively and efficiently. The patient's emergency plan should contain items and education on evacuating, sheltering in place, emergency transportation needs, emergency communications such as phone lists, drug lists, etc., addressing pets and service animals, addressing life-sustaining medical equipment. The regulation requires that each patient have an individualized emergency preparedness plan that is documented in the patient's chart. In addition, we must document that we have had an emergency planning discussion with the patient and their family or caregiver. The individualized plan must be available quickly for review. In order to be in compliance with this regulation, upon admission, the clinician should complete the emergency preparedness planning form within the admission packet. Once completed, this becomes the patient's individualized emergency plan. Also enclosed in the admission packet is the emergency preparedness booklet. During admission or soon thereafter, the clinician should review this booklet with the patient and their family, which covers the second part of this regulation. In order to more quickly and efficiently assess a patient's needs during an emergency, We have developed patient priority codes. All case managers must assign each patient a priority code upon admission and whenever there is a significant change in the patient's emergency planning situation, such as a loss of caregiver or change in health status. These are the patient priority codes. Level 1 is the highest, which pretty much means that the patient needs uninterrupted services and all possible efforts must be made to see this patient. Level 2 is moderate. The visit may be postponed with a telephone contact. However, within 24 hours, the patient will need a visit. Level 3 is low. The patient is stable and does have access to informal support to provide care. Patient will require a visit within 48 hours. Level 4 is the lowest. Visits can be postponed 72 hours or more with little or no adverse effects. The final part of the regulation revolves around the training and testing of our emergency preparedness plan. Training and testing of the plan allows us to determine if our plan could be successfully operationalized during an actual emergency. It also helps us to understand whether the goals, objectives, decisions, actions, and timing outlined in our plan will lead to a successful response. Training will be completed during orientation and annually thereafter. Also, there will be training if something significant changes. Training will include individual roles and responsibilities, threats, hazards, and protective actions, notification, warning, and communication procedures, emergency response procedures, evacuation, shelter, and accountability procedures, location and use of common emergency equipment, and finally, emergency shutdown procedures. The regulation requires that we participate in 2 community-based exercises per year. One should be a tabletop exercise, and the other should be a full-scale exercise. The goal of both, again, is to test the validity of our plan. Throughout the year, you may be called upon to participate in one or both of these exercises. We will also be performing a multitude of other drills and exercises that give us the opportunity to fine-tune our plan. Our goal is that in a real emergency, we're responding with the best action plan. Drills, such as tornado and fire, will be conducted regularly at all locations. These drills allow staff to become familiar with emergency procedures, egress routes, and assembly locations. Again, our goal is that in a real emergency, we are responding with our best plan of action. After any training exercise or drill, we are required to complete an after-action report and improvement plan. This is a document that details lessons learned through the testing and mandates a follow-up process. This documentation process incorporates continuous improvement to the plan and provides continuous up-to-date education for staff. Let's now dive into the specifics of the notification procedures should our incident command system be activated. In general, an alert will be sent out via the CLICK application notifying all staff that the ICS has been activated. The alert subject line will read, Emergency Plan Activation Alert, and the body of the message will include details regarding the emergency and the potential impact to staff and patients. Remember, as an employee of Loving Care, you are required to respond to this message with your location and status. If the CLICK system is unavailable, alternative communication methods will be utilized. Again, a response to this CLICK message is required. If you're at home and it's after hours, you should stay home until you receive further instructions. Your response back via CLICK would be your current location and your status. During working hours, stay where you are or get to safety immediately and wait for further instructions. Again, you're to respond back via CLICK with your current location and status. Once the emergency is passed, another click message will be sent out with the subject line reading, Emergency Plan Deactivation. This alerts staff that the incident has been resolved and we are now operating business as normal. Staff members are not required to respond to this alert. Let's now talk about what happens to our medical records during an emergency. Documentation is critical to maintaining continuity of care and to ensure that we can properly bill for services rendered in a compliant manner. If our electronic medical record is unavailable, all clinical staff should be prepared to document using paper notes. Paper notes are available in both offices for all clinical disciplines. Make sure you are aware of where these are located, and it would probably be a good idea for you to keep a few of them with you at all times. Upon completion of a paper note, please give to the office manager at either location, Darlene West in London and Sarah Queen in Marysville, for further processing. A copy of the note should be delivered to the Patient Financial Services Department for billing and accounting purposes. Once utilized, this copy will be destroyed. The original copy will be securely stored until the electronic medical record is available again. Once available, the paper note will be scanned and filed appropriately. During an emergency situation, we are not released from HIPAA compliance rules. We can release records in imminent danger situations. We can share information to aid in the treatment of the patient or to treat a different patient. We can share vital information to emergency management agency for patients being evacuated, such as no electric and they're running out of oxygen. When in doubt, always check with the HIPAA compliance officer. Our final section is recovery. After an emergency or disaster is passed, we will all be tasked with recovering. It is likely that all of us, our staff, patients, volunteers, etc., will be dealing with a new normal. Homes could be lost, patients, family members, or staff may have perished. It is critical that we have a good plan to recover from these incidents. After an emergency, an agency structure that has been damaged will need to be repaired. It is the duty of the administrative coordinator to work with vendors to get the proper repairs completed. It is also critical that we are able to access our data during and after an emergency. The Chief Financial Coordinator is responsible to ensure data integrity and maintain an updated inventory listing in order to properly recover from an emergency event. This agency is dedicated to helping its employees get back on their feet and accept the new normal that may occur post-emergency. Some of these resources that we can offer are crisis and grief counseling, salary continuation, flexible or reduced hours, care packages including food and water, daycare for adults, pets, children, etc., access to medical care, temporary shelter and transportation, and laundry assistance. This concludes your 2018 Emergency Preparedness and Service. If you have any questions regarding this presentation, please contact Christina Kennedy at the information provided. Please remember to complete the post test and return to Christina or your coordinator. Thank you for your attention.